Looking good.
So welcome everybody. Thank you for joining us today. It's a new venture for us. I'm Richard Adams. I'm a professor of clinical oncology in Cardiff University and Bladder Cancer Centre. But this is a meeting very much for anybody who's interested. So anybody is welcome. For a start, just to let you know, we will be recording the meetings that follow, and they're sort of sub-meetings. We'll continue the recording throughout. And that's really so that ideally we can post these on the web so they can be used for people who aren't able to make it today, or if you're interested in something, you can relook at something or post it out to a PhD student who couldn't make it, or a postdoc, or anyone that's interested. So I'd like to say welcome to you, Happy New Year. I'd like to thank the team that have been putting this together, a number of whom you will meet face-to-face via this virtual concept. But hopefully it's a useful opportunity. It's our first time us sort of exploring this. And we're thankful to a number of groups, the Wales Cancer Bank, obviously, the Wales Cancer Research Centre, who've supported us in structuring this through Asia and Jody, and also for the Centre for Trials Research. Now, what we're going to do first, we juggled the agenda a little bit. You'll have seen most recently those who'd signed up to this. We're going to start with a proper introduction. We were going straight into the trials, but we're going to have an introduction which talks a little bit around the samples and how to access them. So not the specific samples themselves, but some of the background and things. And that will come from Ruby, who's with us today from the Centre for Trials Research. But the kickoff will actually be Alison Parry-Jones, who is the lead for the Wales Cancer Bank here at Cardiff University. And I suppose the main themes before they go into their talk is essentially around the use of samples. We're talking at a focus point in terms of surplus samples that were from clinical trials that have been run either through the Centre for Trials Research in Cardiff, or in fact from the Medical Research Council's clinical trials unit in London as well. So these samples are potentially available for researchers to use. But really, we felt it very important, although a number of these samples have been used in many other studies, not all of them, there are residual samples left, and these are important. These were donated by patients with the trust in us to use them as custodians of them effectively and appropriately, and really to optimize the science that comes out of them. And so it's lovely to engage with people and to advertise these to some degree, but also to try and create links and collaborations when necessary between scientists, both preclinical, translational, and clinical, so that we can optimize use and optimize science for the future as well. There are opportunities here as well that the Wales Cancer Bank does have samples that exist outside of those clinical trials. So where relevant, we can signpost you to groups of samples that are relevant to the type of research that needs to be done and that fits that remit. So without further ado, what I'm going to do, I'm going to pass you across to Alison Parry-Jones, who kindly is going to take us forward and upload and link us in with some of her slides. And Ruby will interdigitate following on from that. Thank you very much.
Thanks, Richard. Hopefully everybody can see my screen. So as Richard mentioned, I'm going to kick off and then hand over to Ruby to say a little bit about the data. So just to reiterate, these are the samples we're talking about today are samples that have been collected as part of clinical trials. Those trials have now closed and closed to ethics. And the Cancer Bank has adopted these samples into the biobank to make them available for other researchers to access. Obviously, again, patients have donated their samples, wanting them to be used. So to be able to make them available through the Cancer Bank does widen that potential remit. Just to say that the numbers that you will see quoted are the indicative of the number of samples that we have adopted. If these are tissue samples, we have not assessed these at the moment for tumour content. So there may be that some of them have low tumour content, some of them may be thin or even exhausted. We won't know that until we look at them. But if you are interested in tissue, then obviously we will assess anything that you might be interested in, certainly before we send it out to you and before you put an application in so that we can actually see whether they're going to be suitable. Because there are 8 different trials, some of the data, sample-related data, will be different. It's not necessarily the same across all the trials. And so the clinical data, the trial-related data, will also be available from the trials unit. We don't hold that in the cancer bank. We just hold any information to do with the samples, and that's really basic sample information. So as far as the application process goes, there will be a dual application. We are working on streamlining a single application form to make life a bit easier. But at the moment, it is 2 different applications, one to the cancer bank, one to the trials unit. So you've got the 2 email contacts there, WCB research applications for samples and the CTR data sample request for data. Both are really encouraging early engagement. It would be good to talk to people to find out what you're interested in, so that we can maybe help guide and help form that application. All samples, as usual, will require a material data transfer agreement if the application is approved before samples are released. So just a few words about the WCB process. If you have an approved application through the Cancer Bank, that confers deemed ethics on your project, so you don't need to go and get separate ethics to do the research that you're looking for, as long as you're using anonymized samples, and that's the way we release all samples. If you do have ethics, if this is part of a larger piece of work that you have ethics, then we would need to see that that approval, so that, and then we wouldn't re-review. There is a cost recovery fee involved in this for us to recover those samples and maybe to do any processing that you require, and we do ask for acknowledgement in any future publications. The applications themselves, it's an external panel. There's nobody involved in the biobank that reviews these. For these trial samples, we are including a representative from the trial, either from the trial management group or from the trials unit that oversaw that trial. And we also we ask for a lay summary, which we make available on the website and in any publications. And our lay members actually review those lay summaries to make sure that they are truly lay and understandable to the general public. The other time that we will do a lighter touch review is if the work that you are wanting to do on the samples is part of a grant, an approved grant that has been peer reviewed by a recognised funder. Then, as long as there's sufficient information within that application regarding the samples, their use and the methodologies, etc., then we will not re-review it. So the application form does need sufficient detail. Our reviewers are very thorough. They will come back and ask for more information if they don't feel there's enough information. And I realise not all of this will be relevant for all applications, but certainly justification of the number and type of samples, what the methodology, any likely clinical impact is always very helpful. Statistics where appropriate, and if there is any preliminary data, again, they do like to see that. We will work with you to look at applications, so we don't just whatever you send in we send out for review. We will discuss it with you and maybe suggest any edits or additions. Our job is to make sure that this gets through the review process for you, so we will help out wherever we can. Just a brief word, if the samples that we're talking about today aren't useful to you, or there may be others that you might want to investigate, the routine cancer bank collection does have samples, tissue and blood samples from over 15,000 cancer patients. There's a breakdown there of the tumour types that we hold, where there's more than 250 donations. And the table just shows you the number of consents we have for the sort of top 6. That doesn't mean to say we have complete sample sets for all of those. It will vary. For some we will have tissue and blood, others we will have one or the other. But they're just there for information in case you're interested. But the samples we are talking about today are from these 8 trials. This is an overview of the trial, the tumour type, the number of patients and the samples available. You'll have more detail about each of these when Richard and Magda go through the trials individually. But as an overview, those are the types of numbers that we are talking about. So I'm now going to hand over to Ruby to talk about the data side of the application. Can't hear you. I can't hear you, Ruby.
Oh,
that's it.
Hi, thank you very much, Alison. So I work at the CTR as a senior trial manager. So the benefit of coupling our research, your research with clinical trial data is that the clinical trials have high quality, extensive data sets such as survival data, disease characterization, treatment data, etc. So if you are interested in accessing clinical data and you want to know more about the data fields we hold, we welcome you to discuss this with us prior to your application. If you want to discuss your research proposal with a clinical expert, there's the potential opportunity to speak to one of our clinical investigators about the trial. And similarly, if you're looking for statistical support with your research, the CTR stats team may potentially be able to help you. And just the same with Alison, the CTR teams are available to assist you in completing the application form and will assess whether ethical approval is needed or not. Your application will be reviewed internally and externally by experts in the field. Next slide, please. Alison? Oh, thank you. Following application approval and contract signing, the CTR will further anonymize the data where it's required, prepare data sets for release, and release the data to you via secure methods such as FastFile. The data application form will require very similar things to what Alison mentioned, for example, the literature search review, a description of your hypothesis, a lay summary, a description of the statistical method you plan on using, and justification for the data fields you requested. And this application will support our governance checks, and it will inform the basis of the material transfer agreement or the data transfer agreement, and therefore it needs to be as inclusive and as accurate as possible. Just to note, some of our trials include data access through NHS Digital. In those cases, additional contracting might be required, but this is only for a small number of our trials. We do request a modest cost recovery for administrative purposes and for preparation of the data. And we also request that the CTR trial team are acknowledged within any subsequent publications. So this is a list of some of the CTR trials collecting samples. There's a broad range of cancer types and treatments. The rows highlighted in green are those that have been banked with a biobank. We'll be applying for biobanking for some of the other trials shortly. So, next slide, please. So if you are interested in accessing samples and or data, maybe you know exactly what you'd like to request, or maybe this has provided you with a few ideas for potential research, or maybe you're interested in samples that we have listed on the table there but haven't been deposited into the biobank yet. We ask that you register your interest with us, and that way we can contact you if any of our sample or data sets that align with your research interests become available in the future. We're also always looking out for experts in the field to collaborate with in future trials. So, for example, if you have a research question that fits well with one of our pipeline early development studies, you could be involved in shaping that research with the trial team. So if you do want to know more, here are the contact details for the biobank and the CTR. I'm just going to pass over to Richard now. Thank you.
Ruby, Alison and Ruby, thank you very much for that. It's really very helpful. I suppose first thing is any questions. We're a small group at the moment. We won't necessarily put out the questions unless they're particularly interesting to the more general audience, but we certainly could do. So anyone do raise your hand or join in and ask any questions about that more generic component. It's beautifully presented by Ruby and Alison. There are various, I suppose, as researchers, dry components to that. There are elements of ethics and proposals. We do very much work on a basis that, as with anything, and I'm sure you'll appreciate, often that sort of review leads to best science, and what we want is best science. So I don't think we're asking for anything over and above that, really, in terms of what we'd expect from a PhD student to supply in terms of their hypothesis and how they want to work with samples. So hopefully it's not excessively burdensome, but hopefully we've been very transparent about that process. There may be different agreements that take place whether you're in Cardiff University or not, because essentially we are the same legal entity if you're on Cardiff University. For those joining outside of Cardiff University as an institution, those processes very much apply, just because that's what we have to do between different legal institutions when we're dealing with samples which belong to patients and in which we're dealing with DNA and cellular material, obviously, which are very relevant to the legal framework within the UK. So any questions come up during that? Nothing obvious? Looks okay. So what we might do then is move on with the first of our trials, if everyone is happy with that. And in fact, I'm going to go first. I haven't introduced Magda. Magda's sitting up there as well. So I'm going to do the first four, which you'd seen there, which are the COIN, Focus 3, FOLFERA, and COPERNICUS trials, which are all, in fact, colorectal cancer trials. And then Magda's going to lead on the following four, and so she'll go through those as well. And Magda is our CRUK Clinical Research Fellow working with the Centre for Trials Research at the moment, and has a significant interest in translational research and science around clinical trials and optimum use of those samples within clinical research. So it's lovely to have her on board as well. So I'm going to attempt now to share my screen. Bring the right one up. This one, yeah, got the right one. So tell me if and when you can see it, which is always the challenge with these things. There's a nod of the head from Ruby. I like that. That's good. So let me put that into visual mode. So essentially, I'm going to talk first through the COIN trial. Now, the COIN trial is a trial I was very much engaged in. The lead of this trial was Chief Investigator Tim Morn, who used to be a professor in Cardiff, now a professor in Oxford, who I collaborate still with a lot in a number of studies. This study, in fact, was led by the MRC Clinical Trials Unit in London, with whom I still do a lot of research. But we are very collaborative across CTUs, and the MRC CTU chose to use the Wales Cancer Bank as their central repository for their samples. And usefully, I mean, demonstrate some of the utility of Wales Cancer Bank, who in fact were UK Biobank of the Year last year, in terms of their really professional approach to accruing samples from clinical trials, as well as their own remit of collecting samples from patients across Wales. And actually, the MRC Clinical Trials Unit have used the Wales Cancer Bank for pretty much all of their big sample trials, which are historic and ongoing. So it's lovely to see that work moving forward. So the MRC COIN trials, because there are two, there's COIN and COIN-B, are trials in patients with advanced colorectal cancer. And particularly, this was patients with disease, which was generally considered incurable, in whom they were presenting to have their first-line treatment or first-line chemotherapy in this setting. So the COIN trial, which was the larger of these studies, was a phase 3 study, enrolled 2,445 patients. It was the largest trial of first-line metastatic colorectal cancer of its time. It was a UK-based study, and it had 3 basic arms within the trial. So the trial essentially broke up into arms A, B, and C, each with about 815 patients. The 2 research questions that were relevant were a question around the role of the drug cetuximab, which is an EGFR monoclonal inhibitor, indicated here in arm B, and whether or not that added benefit to patients in terms of overall survival as an outcome measure when added to standard chemotherapy. And that standard chemotherapy was 2 drugs, oxaliplatin, and then what we call a fluoropyrimidine. In this case, could be either a drug called fluorouracil, which is intravenously, or capecitabine, which is an oral prodrug of 5-FU or fluorouracil. The second research question looked at a strategy, which was that often standard of care for pharma-developed drugs is to start a drug in someone with an incurable disease and then continue that drug until either toxicity means that they can't take it anymore, or that they stop the drug because the disease is no longer responding to it. Now, within this trial in COIN, we wanted to ask the question as to whether or not we could safely stop and start patients on treatment as long as they were responding to it. So essentially, we compared the standard approach of continuing the treatment till progression or toxicity versus an approach where we gave treatment for 3 months in those patients who'd responded to treatment with disease control, measured by CT scans. We then allowed them to stop treatment completely, and we continued to monitor them closely with CT scans. As soon as a following CT scan demonstrated again that the disease was active and progressive, they were then instructed to restart the same chemotherapy regime as they'd had in the past. And these different strategies, essentially 2 trials in one, were an efficient way of delivering research. And this trial was very rapidly accrued across the UK. And I'll come to a few figures on that in a minute. Just in terms of cetuximab, for those obviously interested in the science in here, which I think we all are, So the cetuximab is a sister drug to another drug called panitumumab. These are monoclonal antibodies. They have subtle differences around them, but they impact and bind onto the epidermal growth factor receptor. They block ligand contribution, and they internalize the receptor and have impacts, therefore, on the downstream pathways. The most evident of these that is impactful upon effectiveness of this drug is the RAS-RAF-MEK pathway. And what we've seen, which wasn't visible prior to this study, but this study contributed to the understanding of this, is that those patients with a RAS mutation in downstream pathway, these patients were less likely or not responsive to the addition of cetuximab chemotherapy, whereas those with a RAS wild-type tumor are the group of patients that seem to gain most benefit from the addition of this drug to standard chemotherapy, and that's now within the license of the drug. At the time of this investigation, was an early stage for this drug as well. There was also a theory in the license of the drug that actually the patient had to demonstrate immunohistochemically EGFR receptor on the surface of the cancer cell. So within the license, it was expected that patients would have their tumor cells evaluated within immunohistochemistry for EGFR, and if they had less than 1% staining, then they weren't eligible for the drug. Now, within the COIN trial, we had the opportunity to explore not doing that. So we took all comers, and therefore it presented quite nice opportunities for biomarker exploration. So the two primary papers that came out of this were published now 4 or 5 years ago. So this is an older trial. And they are the first paper, which looked at the question about the addition of cetuximab, and then the second paper, which looked at the role of the intermittent strategy of chemotherapy. You can see on the right-hand side the Kaplan-Meier curves that relate to those studies. And you can see for the primary analysis, in fact, neither demonstrated an improved efficacy of one strategy, one technique over the other. So when we looked at the all-comers for cetuximab, very little difference between them. But when we subdivide that down, knowing increasingly knowledge about biomarkers and subgroups of populations, then there is then a trend towards the efficacy of cetuximab. And sister studies which took place at the same time emphasize this, such that actually this drug is now used in the first-line setting in UK and globally. The Kaplan-Meier lower down demonstrated essentially that there's no significant difference in terms of clinical outcome for patients as to whether they had an intermittent strategy of chemotherapy or whether they continued on chemotherapy regardless until their disease progressed. There was a sister trial to this, which took place as the COIN trial was coming to an end. So it overlapped contemporaneously by about 50% of the patients. This was a phase 2 study, so a smaller study, and therefore not informing of practice as the other two trials within COIN were. But this study looked at slightly different strategies. It tried to combine the questions we'd put into the COIN trial into a phase 2 question. So it had these additional arms, which we in fact did call arms D and E. One was whether we could intermittently use the whole chemotherapy regime plus the cetuximab. I could start the cetuximab safely. And the second one was actually to use cetuximab as a maintenance. And this phase 2 study showed no real significant difference in terms of those strategies, but it's quite useful in terms of demonstrating safety of starting EGFR monoclonal antibodies and in terms of quality of life and impact on patients of that strategy. Now, both of those studies collected samples. You can see the patient accrual on the left-hand side here. So these patients were accrued over 3 years between 2005 and 2008. And the samples obviously accrued over that period of time in which we got, in fact, almost 100% of samples because it was a requirement to have a formalin-fixed paraffin-embedded block for us to analyze their EGFR immunohistochemistry. And all of those samples came to Cardiff and were stored within the Wales Cancer Bank. The COIN-B study contributed another 350 samples, which I've not put on this graph. But you can see these samples came from a broad range of centres across the UK, so 98 centres out of the 101 centres that existed at that time delivering cancer therapy. Just really as demonstration of some of the outputs of these studies, this is some of the data that we see. There was some particularly interesting phenomenon around some of the response rates and the effectiveness of the intermittent strategy and the role potentially here in patients who had a high baseline platelet level, thrombocytosis, and its impact predictively on the strategy one chose in terms of chemotherapy delivery. Lots of data in these papers around subgroups, which gives, I think, some allusion to the types of data that is available from within these trials. Now, the data for the COIN trial is held centrally by the MRC Clinical Trials Unit, but via a similar process to that which Ruby's described for the Centre for Trials Research, we can access that data from the MRC CTU and where that data is appropriately requested for scientific purposes. There are output papers from this study. Now, that's a historical study. I wanted to demonstrate some of those, the particular data around some of the toxicity and the ability to deliver the different chemotherapy regimes, which were very pertinent to this study at the time, both in terms of combination of cetuximab, but also these different fluoropyrimidine combinations. And these have informed various investigations, particularly some led by our own Professor Jeremy Cheadle in Cardiff University, looking particularly at pharmacogenomics in relation to toxicity, etc. So in terms of samples, we collected a baseline blood sample from patients with cellular material from which germline DNA was extracted. And that DNA was held by Jeremy Cheadle and his labs in Cardiff. And a lot of that work has been done with quite large data outputs, which again are held by Professor Cheadle's group. There are some residual samples left, but not many. But again, there's a lot of data that's been extracted from that. The FFPE cores, or FPE samples that were taken from patients, biopsies and primary tumors, in some cases metastases. There are not a lot of blocks that were taken. We have over 5,000 blocks that are held in the Wales Cancer Bank. Some of those are thinner or cut through than others, and some of that would need further analysis. A lot of H&E, which is the standard diagnostic pathway for colorectal cancer images, are held in digital format as well, and may be accessible and therefore are easier to share, but are still considered data. The COIN samples were put into tissue microarrays. There are 26 tissue microarrays originally from the COIN trial data set, with approximately 80 patients in each TMA, with an attempt at least at 3 cores per patient for those TMAs. Next slide. So the germline DNA was extracted from 2,183 of the patients. And I said, we've looked at certain pathway specific elements in terms of gene variants in EGFR DNA repair, which resulted in this paper and resulted in a pathway analysis around the different drugs, trying to pharmacogenetically understand response to treatment for an individual patient. And then there's a particular paper added here, which looked at a metabolism pathway for the fluoropyrimidine called DPYD. And since this paper, DPYD testing, as it's called, has now become a standard of care within clinical practice. And some of this data has supported your ability to do that, and that to be now embedded in the treatment of all the patients I now see for chemotherapy with colorectal cancer. The cause, or I'll go on from that, sorry, there are further sort of analyses which have been undertaken, which relate to some of the EGFR immunohistochemistry, and also elements around the somatic pathways from EGFR. The elements sort of come out in these papers, and obviously those who understand the EGFR pathway, there are sister receptors, HER2 and HER3. There's quite interesting data around how those interact dynamically on the cellular surface, which is analysed in a group of 550 patients from the COIN trial in relation to their response to the EGFR monoclonal antibody. Apologies, that's my dog. Any questions from that? I'm going to drop my slide set. So has anyone any questions from that first presentation? That's the larger of the trials that we have. Oops. Sorry, I lost you then, Polly. So if there's no, well, there's a bit of chat there, sorry, I can miss that. Nothing particularly on the chat around those samples, so I think that's okay. So what we'll do then is I'll go on into the next of the talks, which in this case is the FOCUS 3 trial, which is another colorectal cancer study. I should bring that up. That's COIN again, apologies. So the FOCUS 3 study, while I'm finding those slides, was a study which is also in patients with advanced colorectal cancer. It again is a first-line study of treatment and looked at different strategies to try and deliver that therapy based upon a group of different biomarkers. So 1 second. Let's see if that works. Can you see my slides there? Ruby or Alison, can you see them or not?
It's just a blank.
It's just a black screen.
Okay, I'll go back again. Sometimes a bit fiddly with these things. Oh, here we are. Found it now. Let's try that.
Yeah, that's it.
All good. Thank you for that. So let's put up the slide presentation there. So you got that? Was a full slide set? Good. So focus 3 again was another of the MRC clinical trials. It essentially is been published as well back in 2014, this trial. And it was a feasibility study. That's a study where we're trying to evaluate how we might move forward with other trials. And it led to the development of what we'll call the Focus 4 trial, which is a phase 3 study, which is just in fact closed just recently. And I'm in part of the investigator group from that. And we're hoping to publish the results of the Focus 4 trial in the second quarter of this year. So I've seen the results, but they're embargoed at the moment. So we do also have the samples from the Focus 4 trial, but again, they're not ready to be released through the Wales Cancer Bank at the moment because they're still being used for certain analyses, again, of which Cardiff has contributed significantly to those analyses, along with its collaborator labs in Leeds, in fact. So it's been a nice collaboration. And the Focus 3 trial was a trial where we did collaborate very closely with Leeds and Cardiff to centralize samples and really to try and assess, and this was an early stage in this understanding in cancer, assess patients' biology via certain biomarkers prior to them then entering the study. So we needed to be able to rapidly turn around samples and get those results back through the trials unit to the clinical centers so we could decide what allocated treatments those patients would receive. And we looked really as the primary outcomes of this was trying to understand that process so that then we were in a position to develop the study Focus 4. The biomarkers we used in this situation some were aligned with Focus 4, but there were others as well. There was an immunohistochemical test for topoisomerase 1, and then there was a mutation analysis test for KRAS and for BRAF. There were
Richard, sorry to interrupt. I think we might still be stuck on the first slide.
Okay, sorry. Yeah. Thanks for that. In which case I've got it up twice. Let me just see. I'll go through here. Can you see my next slide now?
Yeah, we can see aims and yeah.
So you missed out essentially the paper which was there, and then the primary hypotheses which were there, which were about delivery of the trial. And then I've just come to this slide, which is basically demonstrating that we were assessing a hypotheses around these biomarkers in relation to particular drugs we used in the first line setting in colorectal cancer. I won't go into those specifically, but they are pertinent to the question. Now, this slide demonstrates the sort of structure of the trial, which would appear quite complex. But essentially what we had arm A in the middle, which was the control arm. So we wanted to deliver a standard of care treatment to mixture of patients with all biological backgrounds. So we had a comparative arm, as it were. And then we had these different arms with slightly different combinations of drugs, which were based upon the evaluation of these different biomarkers in order to drive those different studies. And we had different drugs within them. So again, a good structure normally for biomarker evaluation, although within a feasibility study, normally the numbers of patients are relatively modest. So this is a different format of laying that out and demonstrating how those arms of the trial work and the particular biomarker selection cohorts as far as this study was concerned. This demonstrates some of the numbers of those different groups, both in terms of their biological or biomarker defined groupings, but also then the therapies that they actually received. When we look at some of the outcome data from the study, which is underpowered because that wasn't its primary outcome, you'll see that actually the p-values therefore this are therefore non-significant because that wasn't the power of the study. There are some interesting signals in small numbers of patients suggesting that TOPO1, if it was low expression, demonstrated that the use of irinotecan, which is a drug that's effective on the topoisomerase pathway, then actually was not necessary if you weren't effectively using this pathway in patients with a low TOPO1 expression. But that actually you could therefore give them, in fact, a less toxic regime of chemotherapy called 5FU, essentially, without the irinotecan, and yet you could have, in fact, in this situation, slightly better outcome by actually reducing the toxicity and allowing you to deliver more of the effective drug in this situation. So that gives you sort of an idea of the sorts of data that are available there. In terms of samples, there were 313 patients in this study. We have 339 formalin-fixed paraffin-embedded blocks. You can see some of the biomarker analyses in terms of some of the data we've got on these as far as that's concerned. So we have KRAS and BRAF status and the proportions here. And then we've got the topoisomerase 1 status as part of that as well. And that's, again, much shorter because it's a smaller study, but that wraps up the Focus 3 trial. So any questions from the group from that? Okay. So what we'll do, so my next study in this bite-sized meeting is the FOLFERA study. So I might be a little swifter at getting that on now. And do tell me early, I'll tell you when I switch slides. That way, if I'm not actually functioning, you can actually say. So first thing, can you see the slide set?
Yes, we can.
Thank you very much. So this is again, FOLFERA study. This was run by the Centre for Trials Research, samples held in the Wales Cancer Bank. So the data is available locally for this. So I've changed slides. Did you see that? Are we on the second slide? Oh, good, excellent, that's working, good. So it's a two-arm randomized controlled phase 2 study of irinotecan and 5FU, some drugs I've talked about before and very commonly used in colorectal cancer. And then we were looking at a new drug, which was called an endothelin receptor antagonist. This was a drug developed by AstraZeneca, and we did this study in collaboration with AstraZeneca. And the drug number was this, but it then did develop a name called zibotentan. It's not a drug that AstraZeneca have currently taken forward. And this trial, in fact, did help inform that. So even though what we might call a negative study, it was an instructive study as far as that's concerned, and therefore very useful. The chief investigator for this study is Anne Thomas, who's in fact based in Leicester, and we do work with chief investigators across the UK in terms of running these trials. The background, really, for those who don't know about endothelin and endothelin receptor antagonists. So plasma endothelin levels are elevated in patients with colorectal cancer. It is prognostic of worse outcome. And often biomarkers and drugs are developed looking at patients with worse prognosis and then trying to identify whether those markers of poor prognosis might actually be a target for therapeutic benefit. And there are pros and cons to that model approach. It doesn't always work, and here's an example of that. So colorectal tumor samples express both the receptor, whereas the endothelin B receptor expression decreases compared with normal non-cancerous tissue. Antagonism of the endothelin receptor antagonist has been shown to enhance cytotoxicity, so how effective chemotherapy agents might be when killing tumor cells, particularly in synergy with drugs such as 5FU and irinotecan, which was used within this study. The zibotentan is a specific ETAR inhibitor. It was an orally active, so therefore it's a tablet drug as far as this study was concerned. It may be possible to increase the anti-tumor activity of cytotoxic agents such as irinotecan and 5FU by simultaneously blocking these pathways, and that was the hypothesis that led on to this study. So there's just the pathway represented, and obviously the demonstration of the drug itself on the right-hand side as well, and the number of areas where this may work in terms of inhibition of metastases, prevention of disease progression, impact about angiogenesis, which is also very important for tumor growth and progression and metastasis, and osteoblastic stimulation in terms of bone and bone metastases, also having vasodilatation and apoptotic properties. This was the study, fairly simple design, small study, as I said. Initially planned to recruit 122 patients. It was stopped at 111 because of lack of activity of the drug. But you can see, therefore, we accrued, in fact, 55 patients into the standard arm of chemotherapy alone 56 patients into the chemotherapy plus zibotentan. Primary aim was to establish the anti-tumor activity via a mechanism of progression-free survival, so how long it was until the therapy stopped working. And then there were secondary outputs which related to the use of the maintenance strategy, so the drug when you stopped chemotherapy, and also other approaches in terms of overall survival and biomarker analyses. This was the output from the trial, so it was a negative study, so a placebo arm, so it was placebo controlled, actually doing better than the zibotentan arm. And this was one of the reasons that the drug was then not taken further forward in development, because this, along with a couple of other studies, didn't demonstrate any significant activity of this drug in this setting. As part of the study, there are a number of different data points collected, as we've indicated before, and also, as I've also indicated, samples were collected at critical time points as well, as you can see in the bottom of this table. So archival tissue, and then there were blood tests also collected. Now, the nature sometimes of studies that have been run, which are essentially negative, is that they're less likely to be looked at in terms of biomarker evaluation. So in fact, the samples here have not been rigorously used, despite this study actually completing a few years ago now. One of the components that was embedded within the study, indicated in the box here on the left-hand side, was at the time this was run, which again was a few years ago, circulating tumor cells are quite a new phenomenon. So we did actually work with Manchester and Caroline Dives' labs there, who were really the drivers forward in circulating tumor cells at the time. And we looked at circulating tumor cells from a subpopulation of the patients. And we could see indicators, as we now see quite frequently, of prognostic impact in terms of the numbers of circulating tumor cells and the likely survival of patients who are in the advanced metastatic colorectal cancer setting. So that data is available, but no more. Obviously, CTC is a real-time test still presently, where you need the fresh samples. So that data is there, but there are no samples specifically in relation to that. What we do have, however, is we have the samples as indicated here from these timelines. We've got 92 patients samples with samples available. We have 560 aliquots, so 92 patients with 560 aliquots with a cellular fraction, so that'll be useful for germline data particularly. We've got plasma samples, 883 aliquots from those 92 patients. We've got 68 patients with formalin-fixed paraffin-embedded material, and we've got H&E sections on 48 of those patients. In terms of paired samples, which I think are particularly of interest to researchers at the moment, we've got pre-treatment FFPE and pre-treatment bloods on 54 of those patients. We've got pre-treatment and post-treatment plasma pairs on 36 of those patients. So that's it from the FOLFERA study. Again, rather like before, if you want to link up with us, we've got the contact details there. Any questions from that? No?
Richard, it's Duncan here. Can I just ask a quick question about the nature of the samples? It seems like the majority of samples are FFPE of the tumour samples. Do you ever have fresh frozen material?
Because these are slightly more historical, Duncan, less so. Fresh frozen sort of moved in, but in the research arena, because we've managed to get so much out of, in terms of DNA and RNA, not so much tumors, in FFPE material, less trials have really tried to collect frozen material because of its challenge to do so. Having said that, and again, these are opportunities, this is where things like the Wales Cancer Bank have collected fresh materials, and I know, Duncan, you're aware of a number of those, where that's been more feasible because it's a more bespoke approach where we appreciate the Wales Cancer Bank the need for that frozen material. But generally in these trials, because we've been fairly exploratory, unless people had indicated hypotheses up front for the rationale for collecting that frozen material, they're much less so. Alison, I don't know if you want to come in there.
Yeah, so just to say, there is one trial that we haven't yet adopted. It's another MRC trial. I can't remember. There's another trial that is up for adoption very soon. It does have frozen tissue, but there are relatively low numbers of patients involved with that trial. So I can't remember. Richard, can you remember what the Xerxes trial
Yeah, no, Xerxes was a rectal cancer study as well. So we did take biopsies there from rectal cancer patients who were receiving radiotherapy for rectal cancer. And the study looked at the addition of, again, drug cetuximab, so EGFR inhibitor, and biopsies were taken at baseline and used fresh frozen and in RNA later. They were then taken again after 2 weeks of cetuximab therapy prior to starting their radiotherapy. They were then taken again 2 weeks into the patient's radiotherapy, and then in a number of patients after completion of radiotherapy, but prior to surgery, because these tumors were then resected, a further fresh sample was taken. They're very small, as you can imagine, because these were taken on patients through their treatment. But certainly we have a small sequence of samples from a early phase study, so therefore small numbers of patients in which those are available. That was a study led by the UCL Clinical Trials Unit in London. But again, I was one of the lead investigators on that, so I can fill you in with any other additional information as required.
That would be a very interesting trial for us to take a look at if we can. So I'll contact you offline.
Absolutely, and that's absolutely what we want to do, Duncan, to sort of circulate those concepts. Okay. So what I'm going to do now, I'm going to share my screen again. So I'm probably getting better at this now. The last one I'm going to present today, before I hand you over to Magda, we might have, and I talked to Magda, maybe we have a little 5-minute break before we go on to Magda's, just in case people want a quick rest, as it were.
I think there's a question for Richard.
Okay, I've shared my screen. Where's it? Where was it from? Oh, here we are. Arwen, you've put one up. Is there a mechanism whereby investigators can be involved during the trial design phase so that most relevant samples to them become collected? Yes, Arwen, I think we've got better at that. I think historically we've not been as good, but we're very keen to do that. You may know things such as currently within Cardiff, and give that as an example, the work that Sunil Dilwani is doing on the CONSCOT-2 trial, looking at colorectal polyps in a large screening trial, and how we collect those and what data and material we can get out of it. Certainly, Sunil has been very discussive about that, and that trial's yet to open. So there are opportunities there because we're still putting in another bid currently to look at samples and curation and how best we do that. So yes, opportunity to get engaged. We, in terms of the CTR, are encouraging investigators, and we're part of that investigator team, to actually try and optimize the translational science in relation to studies. Sometimes we are limited by funding, which is a challenge, but the funding is much more easy to obtain when we have appropriate input from the scientists involved in those studies and those sample collections and use of those samples. So yeah, yes, we should do that. And certainly as an initiative through Cardiff, we're very keen to develop that further. And part of the reason Magda's on board is to try and help that sort of integration.
Brilliant. Thanks, Richard. Can I just quickly ask, as a quick follow-on to that, so if funding is a barrier, is it possible when you design your trial and you apply for funding for the trial that, you know, you might say, for example, we're going to collect blood, but perhaps your trial as it stands doesn't need it, but can you say we will collect it anyway for future studies? So then the funding isn't so much of an issue, because the downstream, you know, because you're future proofing. Is that something that's kind of accepted, or would your funding body looking at that say, no, you know, we're not here to fund, things.
It has been a challenge, I have to say, actually, Arwen. So I mean, obviously, you know, I sit on CIEK funding panels where often this is discussed. It is quite heavily scrutinized in terms of budgetary efficiency, etc. A lot of it is scrutinized to the level, and I think not inappropriately, where even where they're not requesting money, then CIEK will review that whole program and want to know that it's robustly developed. There was a time when funding was more readily available just to collect and curate samples without necessarily having developed the hypotheses. I think as both preclinical and clinical scientists, we've sometimes argued that by the time the trial has been developed and the results are available, which may be 4, 5, 6, 7 years down the line, then technologies and techniques will have changed. So therefore, sometimes we're a little bit of blue sky thinking of what we're actually requesting. But there has been a pushback around collecting samples for what would be deemed sample's sake. But I think that is just about getting the heads together of the right groups of people to make the argument that the science is good and that we have some good hypotheses and statistically it is valid. And that's one of the big things that's often missed out, is statistical validation of the sample set that you're going to collect, and is often one of the key criticisms in terms of why these things aren't funded. So that's useful feedback to all of us, I think.
Okay, thanks.
Is it possible to sort of apply for funding the same time when we're applying for trial and funding? When we talk to scientists for their charities.
Good question, Magda. I think there are different types of trials as far as that's concerned. There are the trials in which obviously you need samples and analyses of samples prior to even actually allocating a patient to a particular treatment, in which case it's actually very easy because it's seen as a core component of the funding of that trial, whether you go through an NIHR program, a Cancer Research UK program, whatever it is. And so that's much easier to embed. It is harder still where you have a trial where you haven't really quite defined what you're going to do with those samples. Then generally they generally take those out again. So you then have to go back as a separate application, which has its own challenges, in order to then seek funding to obtain those samples. We have moved to a situation where the NHS, which is obviously our main collaborator in clinical research and is a key importance to deliver, actually need funding to be able to deliver those samples in an appropriate way. They're quite a strapped organization. They need support for research in some of those elements. But there are standardized costings now in place, or template costings, there's a thing called SOCAT, which tells us how much a blood sample costs, how much it costs to extract and send on an FFPE block, and all of those costs are standardized across the UK.
And I think it's also sometimes possible to apply, I don't know whether it's possible to apply for funding exploratory data. For example, you want to test biomarker, but you don't have a sort of setup techniques yet, which could be like one of our trials I will be presenting. They have sub-studies in the trials. Do we have to apply for different funding, or could we just apply for one funding and with the scientist on board?
That's a good question, Magda. I suppose that there are two things. So for pilot stuff where you're really generating a hypothesis, the recommendation in this situation would probably not to use the trial samples first. The one thing would be to generate your workup on the human tissues within samples, let's say from the Wales Cancer Bank, which is why these usually marry quite nicely together when we're exploring applications. Because sometimes we can say, well, actually, we've got 150 of Cancer X. And actually, yes, they're available through the Wales Cancer Bank. And yes, we can give you clinical data on them, but they're not part of a randomized clinical trial. Often the beauty of a randomized clinical trial is about having different subgroups of patients that are relevant to your understanding or a particular drug that you're interested in as a target. And so therefore, the hypothesis behind what you want those samples for is then more specific. But they can work quite nicely together. So there's an opportunity here through the Wales Cancer Bank, who are now custodians of these samples, to put an application in that says, right, I want to do this in 2 phases. Phase 1 might be within our labs, we've identified in cells of Cancer X that biomarker Y is effective and is prognostic. And we've tried some drugs on it, and this seems to be the biomarker of choice. We might then say, well, okay, the first thing we're going to do is give you, based on statistical analysis, knowing how frequent this is, we're going to give you 50, 100 cases from Cancer X to evaluate your biomarker on and get your assay working most effectively. If that's then effective, then phase 2, which you've already put in your application as a suggestion, would be to use the samples from the trial in order to evaluate that biomarker more effectively. So that sort of a phased approach is good science, I think, and is very much supported by this sort of approach. Okay.
There's also another question there around how much data is available on the medical physical history of the patients prior to their entry into a trial.
Okay, that's a good question from Lee. Generally speaking, within clinical trials, we collect a reasonable amount of baseline data. We try not to collect data for data's sake. There are some limitations in that, and different trials do vary. So, for instance, one might want to ask, a typical question might be, was the patient diabetic? How many of the patients are diabetic? That's not always collected. It depends on the specifics of the trial, but it is collected in a number. So sometimes we collect the drugs that patients are on. Sometimes we collect those particular comorbidities. In other trials, that isn't collected. So it comes back to really a dialogue with the trials units around what they have. You can obviously go to the primary papers from those trials, particularly historical trials, and you see actually quite a swathe of data that is available there. Not all the data in the primary publications is, well, all of it will have come from the trials, but there will be additional data held by the trials units as well. So sometimes you can go back, but at least you get a good view by doing that. One of the other things, and particularly I think in COIN, we presented a lot of supplementary data offline or online, sorry. And so again, when reading these papers, and I know as scientists are probably better at this than clinicians, it's important to look at those supplementary papers as well, both in terms of some of the molecular work that's been done and the background to that, but also additional outcome data that is available and data that's available on it. So for COIN, it ended up, in fact, the supplementary papers that are, if you like, online but are not published separately, are actually significantly larger than the primary papers themselves, just because we felt it was important to get that data out and available to the research community. But good question. So I am now going to go on to the last of my talks, and then what I'm going to suggest is we have a sort of 5-minute rest break before then we move on to Magda, if that is okay with everybody. So this is the Copernicus study, so the last of our colorectal cancer studies today. The Copernicus study was a single-arm trial. Actually, can you see my slides? Has that gone on? Are we working?
Yes.
Good.
Yeah.
Okay, fine. Single-arm study. Lead of this was Chief Investigator Simon Gollins, who's a clinical oncologist in North Wales. It's a phase 2 study, so small numbers again. And this was a prospective phase 2 looking at preoperative chemotherapy and short-course radiotherapy for patients with rectal cancer, which was considered at high risk of relapse. So radiotherapy is often used in patients with rectal cancer to try and make the patient's tumor more operable and to reduce the chances of local relapse of that tumor. So it's a very common thing that we use. What we were doing in this study, which was led by the Centre for Trials Research, was to look at this radiotherapy as which is standard of care, but also then around that radiotherapy, the use of chemotherapy, in an attempt to develop studies that might go forward that look at reduced instance of metastatic disease. So not so much the local disease, but what was metastatic. So this was an interesting study, small numbers of patients. Interestingly and very relevant to this study now, earlier in 2020, last year now, a study was reported called Rapido, which had a similar concept, but was done, in fact, now in a phase 3 study. And the setup of Rapido was aware of trials like Copernicus, which helped feed into those sort of study designs. And the Rapido trial looked at short-course radiotherapy followed by chemotherapy prior to surgery on patients with localized rectal cancer, versus what is considered otherwise the standard of care, which was a long course or a 5-week course of chemoradiotherapy followed by surgery. And the paper of that has just come out recently in Lancet, and that suggested that this approach with short course radiotherapy over 5 days, followed by systemic chemotherapy, may actually be better in terms of some of those outcomes, both in terms of distanced relapse of the cancer and to some degree in terms of local control. So this trial has some relevance in relation to that. So the endpoint for this trial, being a phase 2 study, we're looking at much simpler endpoints, so not necessarily survival and disease-free survival in phase 2 endpoints. We were looking at toxicity, how deliverable it was, whether delivering chemotherapy after short-course radiotherapy impacted upon our ability to deliver surgery, and various other factors. We looked at some biological endpoints here, which were quite interesting, an imaging endpoint called MRI, or magnetic resonance imaging, which is a type of scan we do, which gives you a very detailed picture of the rectal tumor, what we call the tumor regression grade. So we do an MRI scan prior to their treatment, we then deliver treatment, and then we reevaluate. In this situation, we wanted to look at the impact of the chemotherapy component prior to the radiotherapy. The MRI was done at baseline and then at 9 weeks after they'd had this introduction of the chemotherapy as their first phase, and so I had some quite interesting data there. We also looked at pathological tumor regression grade. This is an ability to evaluate the primary biopsy versus then what happens in the tumor resected at surgery to see how much impact there is by the therapy on the tumor. And that's a way of looking at the cellularity of the tumor and the context of fibrosis in the tumor, which is normally indicative of a response to treatment. And that's a standardized approach which is available as results within this. A new technique which was used in here was something hypothesized by a colleague, Nick West, who's a pathologist in Leeds, was a thing called tumor cell density. And this is a more automated fashion of trying to demonstrate the impact of a treatment upon a tumor by demonstrating that the tumor cell density decreases. And it does relate to things like fibrosis coming in as well, but this is almost a standardized approach to that. So the results of the study were that this was a safe approach. We could deliver this neoadjuvant or pre-surgery approach safely, and again has led into other studies which have reported recently. It was also demonstrated there's a higher likelihood of delivery of adjuvant therapy. So we use adjuvant therapy routinely prior to this in patients where after the surgery we reevaluate the tumor and then we decide whether or not they have chemotherapy because they won't have had it before. And in this situation, we have a challenge because patients are recovering from quite extensive operations, may not be fit enough for chemotherapy, and then therefore may never receive it. Whereas this was an ability to demonstrate more patients had more chemotherapy by doing it this way prior to their surgery. We demonstrated in the paper that 73% of patients had downstaging on MRI simply with 9 weeks worth of chemotherapy. So this was another evidence that chemotherapy in colorectal cancer is an effective strategy, at least in this situation in terms of its effect on the tumor, in terms of simple measures of response, really, essentially. There are also good correlations with what we call the MR tumor regression grade, pathological tumor regression grade, as I talked about earlier, and this new phenomenon that we call tumor cell density. There's a trend, and there's only a single-arm study, so therefore non-comparative, that the data on progression-free survival were very comparative to historical data also. This was the Kaplan-Meier curves relating to some of the prognostic impact. So this isn't about 2 arms to a study. These are all in the same study, demonstrating some of the correlations that we saw in outcome between pathological tumor regression grade and actually the proportion of patients relapsing from their treatment on the left-hand side. And on the right-hand side, the correlation between the MRI scanned tumor regression grade and prognosis. And although there is a correlation between pathological tumor regression grade and MRI tumor regression grade, they're not the same, they are different. And in fact, this suggested the MRI tumor regression grade might actually be slightly more sensitive as a test, although this is not enough evidence to demonstrate that in its entirety. In terms of samples from this study and data, this gives a snapshot of the data and the time points of that data as we go through. Linking back to, I think, Lee's question, there's a tick box there linking to medical history. So there will be some basic medical history data that is available on these patients. And then at the bottom here, you can see the types of samples that were taken. So we had the original diagnostic biopsy on these patients, and also then we had the post-resection samples on these patients as well. Now, these have been used within the context of the trial, but due to consent issues, we've not been able to then use the samples in an ongoing fashion. However, we have been able to use the cellular and plasma fractions of blood. And we have baseline samples, including ideally, where we could, 2 samples taken at least 48 hours apart for these patients. We then had samples taken at 3 to 4 and 5 to 6 weeks into their chemotherapy. We had then a further sample taken prior to surgery, but with the tumor still in situ. And then we had a follow-up sample taken in a group of these patients as well. In terms of the samples that are available, and there's just a sort of larger diagram of those time points, we have blood samples as the main component now available in Wales Cancer Bank. We do have access to the H&E samples, but not obviously the DNA and RNA from these, from the diagnostic biopsies and resection specimens. In fact, I think from all patients. And they're easily accessible on a virtual pathology link in Leeds. So you can actually look these up by following that link, and you can see all the H&E samples that you can look at the images, and you'll be able to see the differences in terms of some of the outputs from that. And they can be linked in to some degree to the blood samples. For the blood samples, we had 51 patients worth of samples, 211 of these aliquots from those 51 patients are whole blood or cellular aliquots, potentially for germline DNA. And then there are aliquots from these 51 patients, 431 aliquots from these time courses on patients. In 31 patients, we have paired pre and post cycle 3 plasma samples. So again, just to get, and that's during chemotherapy, and just demonstrates some of the use of that. This is just a slide demonstrating the virtual pathology platform at Leeds, where they digitally allow access to these samples, and these are the samples from the Copernicus trial. And then contacts as here. So any questions on Copernicus? Anything in the chat? Nothing obvious at the moment. So what I'm going to propose at the moment is maybe we take a short 5-minute break. On my clock, I'm going to suggest we come back at 13 minutes past 2, and then we'll have the 4 additional studies, which are going to be led by Magda, which involve esophageal cancers, bladder cancers. Magda, what others were there? Pancreatic cancer. I think that was the other one, wasn't it?
Yeah, we've got, yeah,
We're on the spot now, Magda, sorry.
No, no, I was on mute. On mute.
You're on mute, no, fine. So I think we've got pancreas, bladder, esophagus.
Yeah. So we've got lung cancer, esophageal, pancreatic cancer, and bladder cancer, yeah.
Lovely, thanks. So we're back at 30 minutes past. Catch you soon. Do just go on mute and drop your picture if you want to. So just we begin to gather back. Aisha, are you there? You've unshared your screen. Magda,
yeah, I'm just going to try if I can.
That works. Good.
Yeah.
Oh, perfect, lovely. Because I just have to give permissions.
Yeah. You're on slide 3 at the moment, but you can probably.
Oh, sorry.
No, that's fine. That's good. That's great. Right, we are gathering back. That's good. I think you never quite know with Zoom who's actually there or not. So hopefully we're gathering. So without sort of further ado, as I've introduced Magda briefly, as Clinical Research Fellow, CIK Clinical Research Fellow with the Centre for Trials Research in Cardiff, and has just taken on a role through the Wales Cancer Research Centre as well, collaborating with Valindra on early phase trials at the same time. So it's lovely to have Magda here, who did a PhD at Cardiff University. Has submitted that, but waiting for a viva. Good luck, Magda. I think a very positive career with a particular, and I think as many of you have alluded to, a real interest as a clinician in terms of the translation of science, the engagement of scientists within trials at an early stage in order to drive forward the most appropriate trials for the future. So I'm going to leave Magda to talk, and we'll take things forward. Thank you very much, Magda.
Thank you, Richard, for the nice introduction. So now we're going to talk about SCALOP trial. SCALOP trial, very interesting trial, multi-center randomized phase 2 trial for locally advanced pancreatic cancers with up to 7 centimeters in diameter. For patients who could not have operation but could be treated with chemotherapy or chemoradiotherapy. And this trial looked at 2 chemotherapy combinations, so gemcitabine versus capecitabine-based chemoradiotherapy. So that chemotherapy was added on to radiotherapy, and they looked at 2 different arms to identify which combination would be better. Their main primary outcomes were 9 months progression-free survival, and secondary outcomes, the disease response, overall survival, quality of life, toxicities, and also looking at the tumor marker CA 19.9. And that's just to give you an overview of this trial. So patients this trial recruited 74 patients, and these patients were over first 12 weeks would receive 3 cycles of combination of chemotherapy, gemcitabine and capecitabine together. After 3 cycles, they would have assessed disease response. So they would have CT scan, would look at the disease, and if a providing patient had disease partial response or stable disease, then would have been randomized to 2 arms. And these 2 arms would start with the same combination with induction chemotherapy. So it would essentially be the same chemotherapy they had in the first 3 cycles, but they would receive 1 more cycle of this treatment. And then they would go on to radiotherapy. And then 1 group would receive radiotherapy with gemcitabine for over 5.5 weeks, and the other group would receive capecitabine with radiotherapy over 5.5 weeks. And then once that has finished, patient will have again disease assessments and with the toxicities assessment and follow-ups. And this trial results showed didn't show the major difference in progression-free survival at 9 months. It was not significant. However, it has suggested that potentially capecitabine-based chemotherapy, chemoradiotherapy has got better safety and better efficacy outcomes than gemcitabine-based. So you can see the Kaplan-Meier curves. They have not been sort of statistically significant, but I want to show you here the response data that the patients in this trial in capecitabine group. There are 2 patients, for example, with complete response, the patients with partial responses, and there are people who progressed. And that will be interesting to know from samples why some patients have responded and why others did not respond. During this trial, some questions have been coming up. What we have been collecting. So we've been collecting lots of information during the trial, during each cycle of treatment. And I wanted to point it out that we also collected blood samples before induction therapy, chemotherapy, and then another samples just before radiotherapy and also during follow-ups, as you can see here. I'm just going to show you on next slide in terms of samples that we've got blood separated to cellular fractions. We've got cell fractions for 351 patients, and we have pre-treatment samples on week 17 when after induction chemotherapy prior to chemoradiotherapy, and then we have samples after chemoradiotherapy, and then during the follow-up on the week 39. And interestingly, we also have paired samples, which quite interested for a small project here. Paired samples pre and post treatment cell fractions for 38 patients. And as already sort of hinted out, what clinical data will be available. So we will have basic clinical information depending on your research questions, but we will have age, sex, performance status, we will have a stage of the disease, we would have, for example, in this particular trial, we will have a site, if it's important for your project, of the pancreatic tumor, whether it was head or tail, and also for paired samples, for longitudinal samples, clinical outcomes, the 9 months free survival, toxicities, overall survivals, which could be nicely correlated with your biomarkers, and also additional data on planning, for example, planning CT scans if required. And that's a very short, brief overview of this trial. And if you have any questions, hopefully also Richard can help in some of the questions here as well.
Any questions at the moment from the group? No hands I can see, and no particular comments. So that's probably fine. I'd probably go on, Magda, and the people can come back.
Okay, so the next would be another trial. Sorry, I need to share that. But just stop sharing and move on to another one. One second. Okay, next trial. Yeah.
Got that? That's good.
The next trial, sorry, next trial is another trial, which is a simple single-arm, open-label phase 2 study for advanced or metastatic urothelial carcinoma, mainly bladder cancers, with the histology of transitional cell carcinoma. Patients for this trial normally would receive in first-line settings chemotherapy with cisplatin and gemcitabine. And this trial would wanted to evaluate whether additional drug called sunitinib would increase efficacy of this regime in treatment-naive first-line treatment. In treatment-naive patients. And just to give you a brief overview of sunitinib, sunitinib is multi-targeted receptor tyrosine kinase inhibitor, and as you can see, it blocks multiple receptors and have main effects of inhibition of these receptors. There's got direct effects on cancer cells and also anti-angiogenic effects. And it has shown in preclinical and early phase studies that this drug can be effective in urothelial cancers, and it could be combined with chemotherapy, gemcitabine and cisplatin chemotherapy. So this trial aimed to assess whether the addition of sunitinib to chemotherapy will improve outcomes for patients with advanced urothelial cancers. And the primary outcome measure were progression-free survival at 6 months And again, secondary outcomes similar to other trials: toxicity, overall survival, progression-free survival, and objective response rates. And this was a simple study design, a trial with only one arm, and this trial has recruited 63 patients, which were who received 6 cycles of 3-weekly chemotherapy regime, which consisted of cisplatin, gemcitabine, and oral sunitinib. Patients were assessed, of course, at the baseline, during the treatment, and after the treatment. And just to show you the results, unfortunately, sunitinib with chemotherapy was very poorly tolerated, and it did not improve outcomes in advanced urothelial carcinoma. Expected PFS at 6 months has not reached the expected outcome of more than 60%. It was 52%. And the treatment delivery was mainly limited by myelotoxicity, so by neutropenia, by drop in white cell count, and also by neutropenic sepsis. And here the Kaplan-Meier curves, usually they show here their estimated Kaplan-Meier curves. So that's the estimated ones, because when you have a single design trial, you have to sort of compare to your historical estimated overall survivals or progression-free survivals. But interestingly, in this trial, the 21% patient had complete responses, and had also some patients had partial responses. So there was the activity of this drug in these patients in combination. So it would be interesting to know whether they have any molecular effects or molecular structure of the or genetic profiles, which could have explained why they've responded to this treatment, or why some patient has not responded. And we've collected clinical data during this trial, and we collected transitional blood samples before treatment and after 6 cycles of treatment in weeks 26. And we also been collecting information about disease response, and we have some diagnostic biopsy as well. So patients, so blood, we have got separated to plasma and cellular fractions. We have pre and post treatment, and we have almost 100 cell fraction samples, a plasma sample, over 172 plasma samples. We have tissue, FFPE tissue, 35 samples, NHNE sections, 28. And interestingly, for this study, we have pre-treatment FFPE and pre-treatment blood plasma pairs for 17 patients, and pre-treatment and post-treatment plasma pairs for 19 patients. So it could be nice, good, small projects, hypothesis generating projects with this samples. And again, we will have clinical data for you. We will have age, performance status. We will have the location of the primary of the disease, and we will have a grade and TNM stage. And also for stage 4, we will have metastatic sites, depending whether the patient had metastatic disease in lung or liver, and also outcome data, progression-free survival, overall survival, or response rate, response data as well. So that's this trial. If you have any questions for us or for Richard.
So no, how many hands up at the moment, or anything in the chat at the moment, Magda? So
yeah, oh, yeah.
So
I would want to say that we would want to help people, and when they, generating their ideas, how we can incorporate the clinical data, and we will be happy available to help with that. If coming up with ideas, what do you think, Richard?
Yeah, very much so. I mean, as Arwen alluded to as well, I think the best science is done by collaboration. And no one of us can contain all the useful information. So approaches like that are absolutely ideal, and obviously we're open to that. Email address is there evidently, and we can filter to the appropriate people where we don't have the answers ourselves. So that'll be very much engaged as far as that's concerned.
Okay. So if there's no questions, shall we go to next trial?
Actually, there's just another question.
Oh, brilliant.
For all trials, if a study only required samples, the control arm, or only the paired normal sample, would this be frowned upon as it reduces capacity for future studies looking at the test/experimental groups?
So I don't think necessarily frowned upon. It depends upon the science, really. And again, there are elements around that as where we might be able to support that through the Wales Cancer Bank as an alternative. But no, I think there's an absolute requirement to use the longitudinal samples in that way. What we do often ask researchers to do is when they do have that sort of data they'll generate from the samples, then potentially there is a good role to centralize data when you have done your analyses, publications, whatever's required. So that actually, if we want to integrate data in the future, and this is a big focus of what we're trying to achieve at the moment, where we bring all the different bits of science expertise and the clinical data all together into one location, so that people can undertake future analyses where you integrate those bits of science and clinical data. So we sometimes ask for that data to come back, obviously with appropriate recognition of those who've done the work for any future outputs. That where we have serial samples, that that's more flexible as far as that's concerned. Good. Magda, do go on.
Yeah, so its next trial is Phragmatic Trial. So this is a very big study. This was a very big study. It was multi-center randomized phase 3 study, which was looking at the prophylactic dose of dalteparin, low molecular weight heparin, for 24 weeks in addition to standard treatment could improve patients' outcomes. So this trial was done in lung cancer patients at any stage, from stage 1 to stage 4, any histology. So there was a very big study including all patients, regardless of the stage. Normal standard treatment was given according to stage and histology. And this trial was looking at whether the addition of thromboprophylaxis for 24 weeks would actually help these patients to achieve better survival or better outcomes, and also to see whether they can reduce the risk of thrombosis vein events. So the main aim of this trial was to evaluate whether adding dalteparin thromboprophylaxis for 24 weeks to standard care could improve overall survival. And that was the primary outcome. That we're looking at the one-year survival. The secondary outcomes were metastatic free survival, or venous thrombosis events free survival, and toxicity and quality of life. And this was, they recruited quite a lot of patients, over 2,200 patients, and they randomized them to 2 arms. One arm which was normal standard care for any stage or histology or histological subtype, and the other arm was with addition of dalteparin. The samples were collected before the treatment, and for patients who had early stage 1 or stage 2, who had surgical resections, the trial could collect tissue samples. And for patients, for patients who had other treatments but not surgical, the samples were not collected. And after all patients after completion of 24 weeks, we've collected another blood sample for patients, and that was done within this TFRAG study, which was sub-studied to Phragmatic Trial. And the results showed that dalteparin did not improve overall survival in patients with lung cancer. It has shown significant reduction in thrombotic events, but at the cost of increasing clinically relevant non-major bleedings. And this just to show you a couple of my curves, that this study has not showed any overall survival benefits. And again, we've collected, this study has collected quite a lot of information about the patients, and also collected the samples. So interestingly, this study has collected pre-treatment blood samples and FFP for all early stages of lung cancer, and then patient also had another blood sample taken at 6 months. And as you can see, it's quite a lot of samples we have collected. So number of patients which we managed to collect from was 258, that plasma samples, we managed to collect over 1,000, cell fractions over 450, serum over 700, small numbers of tissue, FFPE tissue only 13, and A&E sections 5, and paired samples, quite a big number for pre and post-treatment plasma pairs for 99 patients, and pre-treatment FFP and pre-treatment plasma samples only 10, but it's still in lung cancer, you can still do quite a lot with plasma samples. Not even having the tissue samples to compare to. And again, this study, we can offer you basic characteristics of patients, but also depending on your study, depending on what type of subtype of lung cancer you're interested in, whether it could be small cell lung cancer or whether it's non-small cell lung cancer, or different types of histological subtypes, we could offer you that information as well and give you samples from that with that specific subtype. And also if you're interested in a stage, again, we've got information about metastatic sites, number of metastatic sites patient had. So it could be lots of interesting projects evaluating potential treatment response to the main standard treatments. The patient have received chemotherapy or radiotherapy during that time when they also were receiving antithrombotic medication. So we've got additional data, pathology reports, we've got 1-year survival data, metastatic free survival data, and for some might be interested in other data like venous thrombosis event-free survival. So this trial, very big trial with lots of samples, could generate quite a lot of future projects. And if you've got any questions.
Great, Magda, that's lovely. Yeah, so any questions around that or any of the other talks that we've given? That's the last of our talks at the moment. As we allude to, there are a number of other studies coming through. And so what we'll try and do is develop some mini bite-sized talks as far as that's concerned for the future. So any questions around any of these trials or Phragmatic particularly here that anyone has? Nothing obvious, which is fine. That's absolutely fine. The idea is to be able to sow seeds and let people go away and have thoughts, etc. The plan essentially with these talks is to make them available. So Aisha, who's kindly been recording this, fingers crossed it works, you never quite know with these things. So we reach the end and see if we can save it, is then to try and edit it into the individual talks and then make them accessible. So what we'll try and do is create links through the Wales Cancer Bank, through the Centre for Trials Research, and through Wales Cancer Research Centre, so that you can go back to your colleagues, anyone interested, or you want to revisit these again yourself, and actually pick up on a particular talk. So we'll try and label them by the tumour type, by the trial name, and so that then you can listen to a 5-10 minute presentation again and again as needs be. Or present them at local meetings if that's helpful. Again, the email addresses, etc., are on there for support, advice, direction and steer, and certainly for engagement and collaboration for the future. So again, thank you. I'd like to say thank you to everybody, really, to those who've spoken so far. Any other questions? Sorry, before I do that. Is there anything? No, sorry.
Can I generate the question? Just to maybe stimulate some discussion. In terms of the Phragmatic trial, lung cancer trial, in terms of any molecular data would be included or available for
so there wasn't specifically, so it's a more historical trial before we really got into the arena we are now with lung cancer, with EGFR mutations and ALK-ROS fusions, etc., etc. So it isn't available specifically on this group of patients, it has to be said. Where there is obviously material available, FFPE, which is only a small number in that trial, because these are very small samples, often in patients with metastatic disease for diagnosis, although this was all stages, so there'll be a few others. And so that molecular data isn't there at present, no.
Yeah, okay.
Anna, you had a question.
Yes, thanks. Just a just a very quick question. You showed a slide at the beginning that said what trials you've currently got going, and I wasn't quick enough to like take a screenshot. I just wondered if you could put it up again.
Yeah, Ruby, happy to show that one again. I think it was Ruby you brought it up, Alison.
Yeah, I can stop sharing mine. Yeah.
Stop yours, and we can then bring up that slide deck. Again, that will go out as a mini presentation as well. So you've got to have an introduction, and obviously that process by which things have to, legally take place, unfortunately, nowadays.
Richard, it's Owen. Can I just ask a follow-on question from Anna? So it'd be great if you could send it out, because like Anna, I also, I haven't got overview of all those trials embedded in my head, but
Absolutely.
It would be great if there was somewhere to go to look at it. So, is it potentially on a sort of website on the Cardiff portal, so that only, I really
So yes, so the CTR trials are all on the CTR website, so you can go in there and you can identify all the trials that the CTR are running at the moment. There's a little mini lay summary of each of those trials, so that's point one. They don't necessarily allude to the specifics of samples, so that might be more of a challenge. I think, as I say, what we'll try and do is make these available via links on the WCRC, WCB, and the CTR websites as well as an addition. But the trials themselves, they're all listed, yeah.
And presumably that means you'd also update them then, yeah. So it's not a static thing.
No, ideally we say when they're finished and when they're ongoing. A lot of the ones that are on at the moment that are mainly the ongoing ones. The historic ones are on there as well, but the ones obviously we update now tend to be the newer ones. And we're looking actually additional ways of trying to do that and make that more user friendly also.
Lovely, thanks.
Any other questions? No? Good. And again, well, thank you all for listening today as well. And as I say, we will make these available online, and very happy to catch up through the Wales Cancer Bank or through the Centre for Trials Research or personally.
So there's one more trial to present.
Oh, have I missed one? Magda, my apologies. I'm glad you've come in there.
Someone's interested in the trial for esophageal cancers.
Oh, scope one. My apologies, everybody.
It's going to be very short, just very quick overview of this trial and how many samples we've got available. So I'm just going to share quickly that. If that's okay. Can everyone see this trial? So that's SCOPE 1. SCOPE 1 is the multi-center randomized phase 2/3 study for localized non-metastatic early stage esophageal cancer confirmed by endoscopic ultrasound or spiral CT scan for patients who were not suitable for surgery, either for medical reasons or patient's choice. And this trial looked at chemoradiotherapy with or without cetuximab. We talked about the cetuximab today, which played quite a significant role in colorectal cancer. So this trial evaluates cetuximab in esophageal cancers. So I'm going to just quickly show you, which already Richard has explained, the FGFR cetuximab mechanism of action. Just to mention here that EGFR is overexpressed in up to 55% of esophageal gastric cancer and is associated with the poor prognosis, and that was the main rationale of adding this cetuximab to the main treatment for esophageal cancers. So the primary endpoint was to evaluate whether addition of cetuximab to definite chemoradiotherapy enhances overall survival in patients with of esophageal cancers, looking also at safety and feasibility of this regimen. Primary outcomes measures were treatment failure rate of 24 weeks and overall survival. And this trial looked at 258 patients and randomized to two arms, where patients would receive 2 cycles of cisplatin and capecitabine in the first part of the treatment, and experimental arm will receive in addition cetuximab. And from week 7, patient would receive the same combination chemotherapy, but with cetuximab or without cetuximab, in addition to 5 weeks of conformal radiotherapy. And at the end of the treatment, patient would have endoscopic assessment with biopsies and CT scan review with the patient, how patient responded to treatment, and then fill the follow-up. And this trial showed, as you can see on Kaplan-Meier curves, that actually the chemoradiotherapy without cetuximab was potentially slightly better than with cetuximab. The addition of cetuximab to a standard chemotherapy was therefore not recommended for patients with esophageal cancer for this, in addition to chemoradiotherapy. But during this trial, we again collected lots of information, clinical information, and this trial has collected tissue and blood samples before and after the treatment. And also, as you can see on this slide, that also, in addition to pre and post-treatment, also collected samples at disease progression. And we have samples from 218 patients, cell fractions over 450 samples, plasma over 800 plasma samples, and over 700 serum samples, and whole blood for 18 patients. And paired samples, very quite good big number for pre and post plasma pairs for this trial. So it's a quite good number for good study. And again, clinical data available for this trial, pre and post longitudinal samples, outcome data, overall survival, and toxicities. Additional data potential here is for planning CT scans, pathology reports, and again, the clinical characteristics, patients, age, sex, performance status, and histology stage, and also the site of the tumor, whether upper, middle, or lower part of the esophagus. So it is quite a good study with lots of sample and interesting points to evolve. I just want to point it out maybe, and also generate some discussion, that this trial has not been done with biomarker stratification, and maybe that's why it was negative. What do you think, Richard?
On mute again. On mute again. Yeah, I mean, I think there are issues around the study around one around biomarker selection. I think it's a real challenge with any of the drugs we have. You know, how do you pick out subgroups that are benefiting versus those that might be getting disbenefit? And particularly when we add new drugs, it's the additional toxicities that come in that create the disbenefits. Can you deliver the full active therapy without the toxicity added by the new therapy, which in that individual patient is being ineffective? So it's a really interesting arena, both in relation to their assessment of toxicities and how that fits both the pharmacogenomics and to the patient's individual circumstance, but also to the biomarkers within the cancer themselves and the efficacy of treatments and the combination of them.
And also, Richard, I just wanted to ask the question, which I've already asked you, but I just want to, so we're offering plasma samples and blood samples mainly here, but there were tissue samples collected for this trial. Can you just tell us more?
They've gone to, at the moment, they've gone to, again, they're small samples because they're biopsies. These are non-resected specimens. They have definitive chemoradiotherapy, so without surgery. So they've gone to Oxford at the moment, who are running some analyses on them. They're then sharing them as a part of collaborative with Dundee, I think it is. It was Aberdeen, but then the research has moved. So that they will generate data which may be of relevance as well. And rather, like I said before, the idea is to be able to bring data back so that we can keep a centralized process where samples and data are used by multiple parties. Then we can combine data for optimal analysis in the future. But that work is ongoing. I can probably dig out what it is. I haven't dug it out for this, but they've contracted in with us to say what work they're doing academically.
Would it be possible to create collaborative?
Yeah, absolutely.
Sort of, provide who's doing what, so we can collaborate if we are assessing blood, for example.
Yeah, absolutely.
And I think we may have some H&E images for those. I realised they weren't on the list, but I think we had a lot of those returned from Oxford in the last couple of months.
Yeah, the H&E, I think they were digitally saved as well, the H&Es in Scope 1, because there's a central QA process for it, in fact, led by a collaborator who was at Leeds University, but now is a collaborator in the Netherlands, who we know well, Heike Grabsche. And so those digital images are quite useful as well. And that formed in Scope 1 an additional paper. Scope 1's been rather like coin trial I showed earlier. I mean, there's something like 17 different research papers came out of this one trial that have all been published in relatively high impact papers. So there's a lot of data that is there, both from the clinical, from the radiotherapy, and from the biological perspective, really, certainly pathological perspective.
Yeah. And also, would it be possible for the researchers who have applied for any blood samples with clinical data, if, so, for example, someone else already has requested that, would they possible to put them as together or collaborate, so they can collaborate together, or how would that can be approached?
There's a little bit of confidentiality there, but obviously, yes. I mean, I think that's what we try to do. So certainly in other ones, COIN was a particular case where we'd have a couple of applications on at the same time, and yet they'd seem to overlap. And so then putting the teams together and then subdividing what each researchers were going to do is actually a good way of doing that. So no, it is about building partnerships and optimizing the use of samples, yes. Good. Any other questions? Nothing on the chat? And no hands up, I don't think, at the moment I can see. Again, apologies for interrupting you on that one, Magda.
That's all right, of course.
But that's very useful. And Scope 1's a very useful trial as well, so it's nice to have that. And esophageal cancer is considered what we call a cancer of unmet need. Yeah. So we're running a study called Scope 2 at the moment, which is a similar size but more complex design. One of the challenges of Scope 2, and this comes back, I think, to Arwen's point, and I would think it was Lee's point. In essence, we'd applied to get samples for Scope 2, but in fact, it was turned down. We tried at this stage to get a prospective collection from the clinical trial, but they felt that there was not enough evidence of a biomarker that was relevant to the study that actually would allow them to fund it. That was a CIEK application. There aren't many groups really, and unless obviously others would be very interested in others' views on this, that are prepared to fund simple sample collections. Even with some basic hypothesis behind them. So CIEK has generally been good, but it's become a lot more challenging. And I do sit on some of those committees, and I can understand where CIEK are coming from with it. But it is, there are some lost opportunities, I think, through lack of ways of achieving these sample data sets.
Is it possible for Welsh Cancer Bank to help with that? Alison?
So these are national studies. So Wales Cancer Bank operates within Wales, essentially. Obviously, for the trials, it doesn't, but it doesn't have a reach beyond that in terms of clinical trials, and obviously isn't funded to do it. As I said before, a standard FFPE block to retrieve that costs £20–25 per patient, and then a blood sample costs £15 per patient, which has to be paid into the NHS. So we've got to, be prepared to stump up these costs, and that's before you then consider postage, curation, sample pre-analytics, one might say, in terms of preparation, storage. So although it seems like they're very simple costs, if you try and do that on a large scale for a large number of studies, you very much swamp what you can achieve. So it's a sad situation, but research needs funding. And research needs funding at all levels to ensure that it's actually deliverable in consistent fashion and to a high enough quality. We have to be efficient because obviously funding is a limited resource, but it does need resource in order to deliver it.
Yeah. That's why we probably need to create trials, transitional trials, which will include biomarkers.
Absolutely.
Up front.
Working together with scientists.
Yeah.
Absolutely. Good. Well, thank you, everybody. We will leave it there, I think, without my false dawn. But again, I'd like to thank everybody for our both participation today, but also for those who presented or helped structure today. Jodie couldn't be with us today, but I'd like to thank her. But I'd like to thank the Wales Cancer Bank, the Wales Cancer Research Centre, and the Centre for Trials Research for their input. So thank you very much and take care.
Thank you.